When a patient come to any conditions, after having a good diagnosis, accurate, adequate diagnosis, we usually try to these options, non-pharmacological, pharmacological. Before getting the surgery, we have another look. Is there any opportunity?
Dr. Baka, I think your time is over. Sorry to interrupt you. I understand this is a very vast topic and
No,
it's very
I have
difficult to cover within 20 minutes.
5 or 6 slides is remaining.
Okay, so please.
Yes. Okay. So interventional pain management actually is the option to fill up this bridge. Interventional physiatry actually is a branch of a special branch of physical medicine and rehabilitation. They also try to treat the painful condition by using equipped X-ray, ultrasonogram, and anatomical landmarks. And these were the evidence behind the interventional physiatry. There are other specialties, definitely anesthesiologists, orthopedic surgeons, neurosurgeons also having the key role in here. These are the common procedures that interventional physiatrists now are dealing. And this is the chapter of Bangladesh. There are 80 physiatrists in Bangladesh, but it is still that it is actually practice-based. A huge number of dedicated setups actually are required to develop. Good news is that since 2013, physiatrists are doing in this well, and you get the information using the following link. And my practice, I already have said, I am practicing in a secondary level hospital. Most cases I use the surface anatomy guided procedure, but I am lucky enough to have musculoskeletal ultrasound facilities is to learn to improve. But we are facing huge problem that I described this article. This is my latest publication that although I have limited scope to work, but I do this research work. And this one is the piriformis syndrome and fibromyalgia clinical diagnosis and successful treatment. This is the ever first report where I describe fibromyalgia and piriformis syndrome in the same patient, and same patient I describe if any patient have the somatic component, if you don't this somatic component immediately, then this is the patient may develop central sensitization. Here piriformis syndrome is the somatic component and fibromyalgia is the neurogenic component. Both can happen in a patient if you don't treat somatic component immediately, accurately. In fine, this is not the only physiatrist only duty, just write down some physiotherapeutic exercise or physical hazards. This is their first duty, like you, to diagnose the condition, follow basic statistics to diagnose disease, identify disabilities, impairment, and handicap, as it is their primary aim to improve the quality of life. They must have definite plan for pain. They must have intervention if scope is available. Follow-up also important. At the same time, research and mass publication is also another important thing, as if you don't have enough research, new knowledge will not be created. This is the much more important thing that I think. Thank you very much for being with me over the last 20 minutes and showing my apology, taking few minutes more. Thank you very much.
Thank you, Dr. Baka. It's a very nice presentation, though I understand, sorry for that. The time is very short. Anyway, the next topic is when to refer for surgery. The speaker is Dr. Amit Thapa. May I invite him? He is the Associate Professor of Kathmandu University of the Department of Neurosurgery. Dr. Thapa, please.
Good afternoon, chairpersons, dear seniors and colleagues. Without wasting any time further, first of all, let me thank the organizing team to allow me this platform to present my ideas on the same. I will like the help of the three wise questions: why, when, and which conditions to refer, to answer the query which has been put forward, when to refer these patients. And of course, we'll talk about those conditions where there is always better late than never, situations where the surgery can be offered. Now, I take the liberty, being a neurosurgeon, to only talk about neurosurgical procedures rather than any other surgeons taking care of the pain procedures. Now, we all talk of multidisciplinary team, which we all know about what it contains. But when we talk of multidisciplinary team, it's always once exhaust a modality available to a specialty, then he takes the help of the other modality to take care of the patient. What I profess is rather interdisciplinary team. The moment you see a patient, this has been talked about in the last 3 days, there are some patients who you cannot only treat. there will be use of physiatrists, there will be use of psychiatrists, there will be use of some other people, some other department who can also help the patient at the same time. So rather than consuming the patient's money and time over your own treatment, it's always better an idea to take an interdisciplinary approach. And this has come in various literature, which was published in 98 and 2000, where they have compared the conventional pain treatment as to the interdisciplinary approach, and they have found not only a good satisfaction in the patients, but also cost effectiveness. Hence, we all know about this vicious cycle where the patients get dissatisfied after a long list of treatment. As a surgeon, I'm not going to use a concept of 3C, which a medical representative used to just trade off their medications. I think most of the people would know 3C. They first try to convince you. If they cannot convince you that the product is good, then they will coerce you by saying that the medicine is cheaper. And then at the last, they will try to corrupt you by giving some gifts. So this is not my job. I'm only going to tell you philosophically as well as evidence-based as to what is much more better. All symptoms are not inflammatory, and that's where the surgeon's roles come. There may be conditions which are benign and surgically curable, and in some situations, late referral can still be detrimental to function and the life. And as a last resort, and as a